Okay, so now we're going to talk about magnesium. I usually like to talk about magnesium after I talk about potassium because potassium and magnesium, I kind of think of them as being sisters. So I kind of think of Maggie and Patty, magnesium and potassium, Patty, they go together. So wherever magnesium is, usually Patty's going to go there too. So if Maggie and Patty are both low, if Patty's low, Maggie's going to be low. If Maggie's low, Patty's going to be low. Vice versa when they get high. So just think of these guys as going together. And I want you to think of magnesium as a muscular nervous system. So our nervous system response, more so than the cardiac. There is cardiac involvement, but I want you to think more neuromuscular. So this is 1.6 to 2.6. So I want you to think of hypomagnesemia. So this is going to be below 1.6. Now, why would somebody have a low magnesium level? Well, there's two reasons. One, they're going to have an increased magnesium output, so they're going to be getting rid of magnesium, or they're not going to be able to get it in or absorb it. So talking about output, they're either got nausea, they got vomiting, diarrhea, NG suctioning, so we're getting rid of that magnesium. We're giving them a diuretic, we're giving them Lasix, we're giving them thiazide diuretics, and we're causing that magnesium to leave through the urine. So that can be a problem there. Or it could be we're not taking enough magnesium in, or we're not absorbing it. So there are certain people who just don't absorb certain things. So for whatever reason, their duodenum, whatever reason, they're not able to absorb those magnesium or those electrolytes, so they're not getting them in their body. We do see that sometimes in alcohol disorders because they can't absorb that magnesium with the alcohol use. Malnutrition, some of our elderly patients, some of our alcoholics are malnourished because pork chop in every can, so they're not eating the food, they're drinking the alcohol. Laxative misuse, which we'll talk a little bit more about that. Crohn's disease, celiac disease, ulcerative colitis. So if you've got your colon and you've got a 10-inch section of nothing but sores inside that colon, that's not going to absorb any potassium because it's trying to heal itself. So it's not going to be able to absorb anything. So it may be an absorption problem. So if it's one of these over here, any of these, we need to find the underlying cause. Why is that magnesium level low? And then treat that cause. So what are you going to see in your patients? Well, if your patients have a low magnesium level, their muscles are going to be very hyper. Okay, so it's kind of the opposite. You think hypomagnesium, they should be hypo, low, but it's not. They're going to be very hyper. They're going to have hyperactive DTRs, which is deep tendon reflexes. So when you take the little hammer and you bang it on your knee and your leg's going to go wah like that. A positive Chavacic and Trousseau sign, which I will talk about those in the calcium section. That is all muscular, skeletal, and nerve conduction. That's what you're going to see with your low magnesium levels. So you're going to have hyperactive stuff, but it's going to be hypomagnesemia. Now, I'm going to just point this out. I'm not going to put it on one of your tests, but you may see it on NCLEX. You may see it someplace because they love to use this one. But torsades de pointe is a specific cardiac rhythm that only occurs with hypomagnesemia. So you will see it on NCLEX. It'll say the patient comes in and presents with torsades de pointes. What is your first action? Well, your first action is going to be to correct that magnesium level, okay, because they have hypomagnesemia. So that's what's going to correct that torsades de pointes. If we do not correct this, that patient will die. This is a very uncommon rhythm. So you might be a nurse and you've worked in the ER for 25 years. You may have only seen torsades de pointes 4 times, maybe less. So it's not something you're going to see very often. So it's something that's going to come up on the monitor. You're going to be refreshed on it every year when you go to all your education places. They're going to talk about torsades de pointes, but you rarely are going to see it. So the first time you ever see it, you're like, oh my gosh, that's what that is. So we need to get this person some magnesium because that's what's causing this. So that's just a little tidbit of information. All right, so what are you going to do? Well, like I said before, you got to treat that underlying cause. Why are they having that? And then you're going to have to give them magnesium. So if you're giving them magnesium, the best choice is oral. However, if they've got diarrhea or their magnesium level is super low, we're probably going to give that IV. We're going to get rid of any medications that are going to cause the body to lose magnesium, and we're going to encourage a lot of foods that are high in magnesium. It's kind of important, even in the fundamentals level, especially at the fundamentals level, learning the diets and knowing what is high in potassium, learning what is low in potassium, learning what would be a good thing on a renal diet, learning what's going to be in a sodium restricted diet. All those kinds of things are going to be really important, because that way you know when the patient gets their chart or their tray, do they have what they need? Is that what they're supposed to be getting on their tray? Because sometimes dietetics makes a mistake and they get something up that's not supposed to be there. So make sure that you're looking at all that and that we're not making a mistake with our patients, because that can be, a problem. All right, hypermagnesiemia. This is where your magnesium level is greater than 2.6. So why would something get high? Well, if the kidneys aren't working, they can't get rid of it, so it's going to get high. Maybe we're taking medications that has a lot of magnesium in it. If you've ever heard of milk of magnesia, certain laxatives and things have magnesium in them. Some people will take magnesium at night to sleep. Some people take magnesium for to help them go to the bathroom. So all of those magnesium things can cause those levels to be too high. Dehydration can cause that. Alcoholism and malnourishment. I know we just talked about this in low too, but it can also cause high, depending individually on what your patient has and how that they are doing. So what are you going to see? So remember in the hypo, where they're everything is like going crazy and everything's spouting and going, this is going to be like low. So this is that patient that their respiratory system's going to get really, really low. Their DTRs are going to get really, really low. They're going to get lethargic. They're not going to be moving much. They're going to do all those kinds of things. So that's what we want to watch for in hypermagnesiemia. Now, what I've seen, and this is just because I do a lot of OB. In OB, we use magnesium to stop labor. So when we use magnesium, we use high levels of magnesium to stop labor or to bring their blood pressure down when somebody is in a preeclamptic state. So we have to monitor these neuromuscular symptoms. So a lot of times we will really watch our pregnant moms, and if their respirations get, below 12, we got to turn that mag off, because they got to be able to breathe. So, or they get diminished DTR. So a lot of them will be on hourly DTR checks, just to make sure that our mag levels are not getting too high, and they will get daily mag checks just to make sure that we're staying where we need to stay. Okay, so what are we going to do about high magnesium? Well, we're going to make sure we're doing those focused assessments. The assessment tool is the best thing we can give you. It's what you're going to use when you see a patient going downhill. You're going to go, oh, yeah, I think that's not okay. So looking at their vital signs, looking at their level of consciousness, looking at their reflexes. That's going to be super important. I know a lot of people, I'm just going to bang on their reflexes. Oh, they're fine. No, this is where those assessment tools are going to come in really, really handy. Notify that provider if you have any changes, if you have absent or any changes in those reflexes. You're going to give them those loop diuretics. This is for high. This is hypermagnesiemia. And a lot of your IV fluids may have a little bit of magnesium in them, so we want to make sure that they don't have any magnesium in them because their mag's already high. We're going to give them calcium gluconate, which I know this sounds crazy, but if they have a high magnesium level, we will give them what we call calcium gluconate if they're having cardiac changes, and that kind of quickly lowers that magnesium level. So calcium gluconate is kind of like the antidote for hypermagnesiemia. Okay, so that is the end of your MAG. Remember, MAG and potassium go together. Maggie and Patty, where they go, they both go the same way.